Good morning, afternoon, evening, depending on where you are, and welcome to Chart Chat Round 11. I'm happy to be here along with my friends and colleagues Jeff Shaffer, Amanda Makulec, Andy Cotgreave, and let's jump right in because we have a lot of things that we want to cover today. So first of all, our agenda. Sadly, we will have no recap from the last round. We will have to wait until our next episode for Andy to eviscerate me for my opinions about Voronoi tree maps. I look forward to having those discussions again. Jeff is going to take us through a little bit of the history behind the Flatten the Curve diagram. Amanda, oops, sorry about that. Amanda is going to explain why it's unlikely to just be a simple curve and the ramifications of that, and people should be prepared for that. Andy is then going to discuss visualizations that have had a profound impact over the last couple of weeks, as well as some that have caused a lot of problems. And Amanda then is going to lead a discussion that we're all going to have about the ethics of publishing and amplifying data visualizations during the crisis. We will have what I hope is invigorating discussion, open things up to Q&A, and the only thing I might change about the agenda slide at this point is I would probably have all these incredibly bored people working remotely as opposed to in the same room, at least for now. And with that, I'm going to stop sharing, and I'm going to turn things over to Jeff. Jeff.
Thank you very much. Going to pick the right screen here to share, and hopefully you are looking at my screen. I see a nod. Is that correct, Steve?
We are good, Jeff. Thank you.
All right, thank you. I feel a little today like I'm the R.J. Andrews of the group, I guess, talking about the history. I do have a new theory, though, newly formed, that the coronavirus was actually started by cats and dogs everywhere, because who else gains from the shelter-in-place thing? I know my 3 dogs at home have been on several more walks per day than they would normally get. So there you go. That's my theory of how this all started. I don't know who pointed this out to me, but Amanda reminded me of it on our call. Things we've learned in the last few weeks about the coronavirus is a novel virus and the mortality rate. But I think more than anything, we all know that we touch our face. I can say for sure I lean on my hand quite a lot. So that's the one I'm trying to figure out. All right, a little bit of history about all this. Most of our history about what we're at today, especially, what the topic of the day, the Flatten the Curve, comes from what we know about the 1918 pandemic, the flu. Some interesting things I found on this. I think RJ would probably be proud of this. Some really, really cool graphs from 1918, death rates from influenza. This comes from a monthly bulletin of the Department of Health back in December of 1918, the NYC Municipal Library. And there's some really cool charts. Interesting that we're talking about age of people who are infected, male versus female. They even broke it out single, married, and widowed. I thought was interesting, but the age groups of who was being affected, and then these curves that really, this is a curve from 1918. That's something you're going to see here in a minute, right? Curves that we talk about all the time. So the deaths from daily deaths that they were charting from influenza and pneumonia, and then started looking at that by cities, started looking at that by age and other things. The cities are interesting, and we'll talk about that here in a second. Philadelphia tops the list and will be a topic here as we go to the next couple slides. But that really is kind of at the heart of this topic of flatten the curve. And so these cities are really interesting. Looking at the cities on the list, you'll see specifically that we'll talk about here in a minute, Philadelphia at the top of the list and St. Louis toward the bottom of the list. So just kind of setting that up for you. In 2006, there was an interesting chart that sort of plotted these cities and these curves as they're sort of each city is kind of on its own timeline within a few weeks of each other. You'll see most of them kind of peaked around the same time, but a couple of them are sort of shifted off to the right. When we talk about the history of where the flatten the curve comes from, though, it seems to all point to a paper in 2007, specifically these two cities that I pointed out, Philadelphia and St. Louis. Now, I think there were 17 some cities, yeah, right there it says that, 17 cities that they looked at in this paper. And this is really the genesis of this flatten the curve idea. Broadly speaking, Philadelphia was late to the start. They kind of ignored the early warning signs, specifically had a large parade in the city, and St. Louis, on the other hand, did some very specific things. These things came to be later called, well, in the 2007 paper, they referred to these as NPIs, non-pharmaceutical interventions. And so that was the discussion of this paper in 2007. A chart in that paper really talks about the overload on the hospitals. That's number 2 bullet point there. So 3 things happen is, 1, you delay the peak of the outbreak. Number 2, because you're delaying it, you decompress the peak on the hospitals. And 3, potentially diminishing the overall cases. Now that's a very generic view of this. If you go back to the Philly versus St. Louis, it's a little more nuanced than that, right? But this is the concept of the NPIs. For confirmed cases, you isolate them and you treat them. For confirmed cases, you voluntarily home quarantine, where they stay home and they quarantine themselves. And then the next steps are dismissal of students from schools and social distancing measures. So these are the things that were discussed in that paper. If you jump forward 10 years later to February of 2017, that paper was revised, I guess, to say, and its guidelines that the CDC uses now for mitigation of preventing a pandemic flu. And so it's really the same chart that we saw before, a little bit more annotated. They talk specifically about the reduced of the peak cases and so on. And just a couple things I'll point out here. This is from the 2007 paper. The hypothesis is that rapid implementation of these multiple NPIs significantly reduce the flu transmission. And but there's the viral spread will be renewed when you relax those measures. So that's something we don't often hear about when we talk about flatten the curve. We're really kind of talking about just the peak of the mortality, or peak in this case of hospital. One of the other things interesting is that in the 17 cities they observed, the cities that implemented the NPI sooner had lower peak mortality during the first wave, what they call the first wave, but greater risk of a larger second wave. So I think the last thing I just point out is that the curve doesn't just necessarily flatten. There may be other shapes, and Amanda's going to talk about that. But going back to this 2007 paper, specifically, they talk about that double hump, right? That second wave that comes from releasing some of those measures. And if you dive into the history of what happened in St. Louis, it's really interesting because they didn't just stop everything like some of our states or cities are doing today. They kind of slow rolled those precautions out, and then they slow rolled them back in. They opened schools to close them again. They opened businesses and closed them for a few days and then opened them again. So interesting to see sort of the difference of how we perceive that today. So I'll just remind everybody, social distancing is one of those NPIs, and I don't know what that'll mean for the Olympics. I know it's going to be delayed, but that's the new Olympics symbol for practicing social distancing. And I guess the other thing, our governor keeps telling us that we will have availability of toilet paper. I will tell you that there there is no toilet paper on the shelves at our grocery store. And, when the neighbor's house gets TP'd, it was listed on Zillow for $12.5 million. So I thought that was kind of fun. Found that on Reddit. So there you go. And with that, I'm going to pass it over to Amanda. That's our brief history of our Flatten the Curve.
And there is a question I'm going to want to hold for a minute, which is the whole discussion of the area under the two curves and what that means, and that the number of cases may in fact be the same, but by spreading it out over time, you greatly reduce the strain that's on the healthcare system and the number of deaths. This may come up when we discuss with Amanda. And Jeff, for the next time we present it, just call that Tokyo 2021.
Yeah, there you go.
Yeah.
Thanks, Jeff. That's a great background in terms of all the history behind this graphic. And I think what's interesting is the graphics you showed didn't have that dotted line for health system capacity on it, right? And I think we've kind of seen that addition of that dotted line has been kind of critical to understanding the implications of what this graphic means. So I think a lot of us have at this point seen this excellent animated explainer that Harry Stevens did for the Washington Post, talking about kind of what the implications are of our individual choices around flattening the curve, what the different models might look like in an illustrative small town. And I don't think I've ever had as many non-data viz people share a data visualization with me as I did with this one, of the text messages or the Slack messages or anything else. And it actually is, as I understand it, the most viewed article of all time on the Washington Post site. So if that's not speaking to the value data visualization is bringing to people understanding what's happening right now, I don't know what is. So I think that Harry has done a great service to the broader kind of public health community and the broader public by helping people understand what these curves kind of could look like. And you can see that as we get down to the ends of the models and we get to what they look like, they don't just look like humps that happen in different spots, right? And we can dig in more, Steve, in a little bit about that question of the area under the curve. But the goal is that we want to keep that brown area small, right? We want to minimize the number of cases. We want to minimize when those number of cases exceeds that line of health system capacity. So one of the things I think this explainer does really well is help to try to bridge this gap in between people like many of you on this webinar today probably, who routinely interact with and go ahead and look at charts and graphs of information, right? We have mental models for making sense and understanding these things, compared to people in the broader public who may see a lot of charts and graphs in journalism, but aren't interacting with them every day. And I think that the Flatten the Curve explainer and the Flatten the Curve graphic, this simple Flatten the Curve graphic makes a big difference in terms of helping understanding. But we also face the challenge that at the end of the day, as George Bach says, all models are wrong, but some are useful. The Flatten the Curve model or concept, this idea of where do cases happen and when do cases happen and what do they do to our health system, is a big challenge for us to make sense of when we start to kind of internalize this mental model of a simple Flatten the Curve graphic that has basically two little lines with the area underneath them and this healthcare system capacity line. So as we think about kind of how this model translates into what we're going to see in the real world, I think we're going to see a lot more of those wiggly curves, and that's what we're seeing in some of the models coming out now, than we might expect to see based on these lines. So the next challenge we have as data visualization folks and communicators is how do we help people grapple with some of the uncertainty and the wiggliness of the lines, right? I mean, what's the line going to look like at the end when we plot this over the course of 2020? Is it going to be one long flat curve that doesn't exceed the healthcare capacity? Is it going to be a couple bumps from when we do different areas of social distancing? Is it going to look like a kitten or baby Yoda, which we know were featured prominently in a couple of the iterations of Flatten the Curve? I'm guessing not a kitten, but we can expect that there'll be some wiggliness to this curve and that this curve might look different in different locations throughout, say, the US. In different states if we start looking at more granular information. Because ultimately our questions about healthcare system capacity are in a lot of ways very local. So there are all these different things pushing on the curve, right? I like to think about this if I was to make the curve out of clay and I've got a curve out of clay laid on my charter graph paper, that I have all these different things pushing on that curve that can change and shape what that curve looks like. So let's look at some really sketchy and unscientific examples of what that curve could be shaped by and change. And let's look at a really specific one, right? So if we look at something that we can look at for COVID-19, R naught, the number of new infections we can expect for every one infected person. When R naught, those number of new infections, is really high, that curve spikes sooner or faster in terms of number of days. As R naught goes down and gets closer to or under 1, we can see that it actually goes ahead and flattens out. R naught is calculated based on other data and information and inputs. It's not just a fixed number that stays always static and the same over time. And I would highly encourage you to, I seldom, I think, send people to Wikipedia, but if you look at the case fatality rate webpage on Wikipedia, there is an excellent explainer of the uncertainty in case fatality rates and R naught around COVID-19 as an early stage epidemic or pandemic. If we look at some sketchier graphs and charts, if we think about things that could push that curve over to the right, those pressure points or those things that are pushing it right, slowing it down, slow the spread, general social distancing, frequent hand washing, case isolation so that we isolate people who are known to be sick with COVID-19, school closures that minimize interaction, these all could push that curve all the way over some way to the right. Then we can think about how those individual actions have a real impact. So a great visualization example from Reuters looks at contact tracing in South Korea. And lest you think that your own individual choices about doing those small actions that can push that curve right don't have a difference. They've actually found through contact tracing that the majority of cases in South Korea can be traced back to one index patient, patient 31. And I'd highly encourage you to go take a peek at this Reuters piece. We'll share out a link to make that available in the chat box. But I'd highly encourage you to look at it because it shows the complexity of contact tracing, something that helps us understand kind of who interacted with who and where might additional cases be, and also helps us think about kind of what the impact of our own individual actions are. And they've updated this piece of data journalism since it first launched, when it was a much smaller case number. And at this point, as of data from March 18th, the church cluster that's been linked back to this one patient 31 who I have the utmost faith was inadvertently spreading the disease. This is not something we do on purpose. It now represents all of these people. And as you see them fill that screen, I hope that gives just a sense from a visual perspective about the implications our individual choices can have. As hard as things are right now to stay home, it's so important that we're making those individual choices because those push on that curve, right? We also can push the curve up. We can make that number spike higher and faster. And one thing I want to touch on is that that doesn't necessarily mean that there's more illness. It can mean that. But if we have more widespread testing, or as we saw in China in mid-February, change the definition to be more inclusive of different ways of defining confirmed cases, when we have more testing, we will identify more people who are infected with COVID-19 and can be confirmed cases, and that number will go up. So as we look at the changes in the case numbers, we also have to do our best to look at changes in testing numbers. And I know the COVID-19 tracking project is doing a great job trying to aggregate and pull together a lot of disparate information from different states on testing numbers. It also could go up because we do poor implementation of social distancing or even limited access to care that force sick people to stay in their own homes and interact with more people who they then could infect. We also could push the curve back and it could spike sooner and faster by things like lack of access to care, limited PPE for health workers that cause our health workers to themselves get sick and not be able to provide care, and misinformation that can hamper social distancing efforts. So you can see how this curve is getting pushed and shaped in different ways by all these forces. And while I've kind of shifted it back and forth in different ways, it also gets pushed up and down. We also have to remember that this dotted line of health system capacity itself is flexible and can move a little bit over time. We could have surge capacity that pushes our capacity up. We can have health workers who are sick and can't come to work because of their lack of PPE and getting sick from the virus themselves. So that pushes our capacity down. We could buy or manufacture more PPE or ventilators, pushes capacity up. All these different pushes and pulls make this dotted reference line not one fixed number, This isn't as simple as just putting a reference band, right? This is saying, like, what are all the different factors in our health system that influence how we respond? And I think a great example of trying to take this and making it local, where it really matters, and using this example from the US, is this explainer and visualization from ProPublica with a model from the Harvard Global Health Institute that looks at, based on the percentage of US adults who are infected over a given period, how fast it happens, 18, 12, or 6 months, what share of hospital beds will be occupied. And the bright red is getting to over 200% of beds. And what this does, interestingly, is instead of using, if you look at it, instead of using administrative units, they've used hospital referral areas. So you see these odd shapes, which are hospital referral areas, that better give us a sense of where healthcare capacity is and what regions different hospitals or major hospitals are serving. And so looking at stuff that's more local, because ultimately epidemics are local, is really important. And I think we've seen now in the examples from the history from Philadelphia and St. Louis that we can see that these intermittent social distancing pieces actually cause us to have this curve go up and go down, right? As we do intermittent social distancing, we may flatten it again and may see it increase. And so I think this is some iteration of this kind of wavy line is the most likely to be what we see happen, because ultimately we'll have to make local decisions at our city and state levels around how much additional time we keep businesses closed, we keep schools closed, and we practice this intermittent social distancing. So similar to how we actually interact with and think about identifying cases of HIV and doing targeted prevention campaigns and testing and trying to roll out more services for clusters where HIV is on the rise or increasing. We can do a similar kind of hotspot, targeted hotspot approaches to how we look at COVID-19, being a bit more surgical, I've heard, in our response, which is a great idea if we have the data to actually know where the disease is, right? That's the really important piece of this, is more testing, better knowledge of where the disease is. We can take this mental model, and I think this is a kind of key point to end on as I wrap up my really sketchy slides, is an actual graph from a paper from Imperial College. Again, remembering that all models are wrong, the best are useful. So this was an example of one of the models that came out about a week ago about what could happen based on different non-pharmaceutical interventions in the US and the UK. And this chart is specifically for the US, because those are what our theme has kind of been today. But when we look at this chart, we now know, because of the flatten the curve infographic that is a concept or a model, we know how to interpret this chart now, which is really cool, right? We have increased our knowledge and our understanding of how to interact with this epidemiological model because of the flatten the curve chart that we've learned from the different news media and from Harry Stevens's graphs and charts on the Washington Post. We know that we want to look at that red line, critical care bed capacity. We know we want to look at how that other line changes and be worried when it goes above the red line. So we've really built a new mental model for understanding how to look at the outcome of this model. And as we zoom in, we can see that orange line, for example, really wavy, right? It's really wavy. And you can see how that line oscillates and changes based on different things that are happening over time. And this model takes into account those non-pharmaceutical interventions. It does not start to take into account, say, when we have an effective treatment that may be able to help people get better faster, be released from the hospital sooner, and not requiring critical care. And I would point to one final thing to watch as you're consuming all of this data and information, or as you choose to consume it, coming out with these models, is the y-axis on this chart and these other charts will change in some cases, right? This is looking at critical care beds occupied per 100,000 population, which perhaps is a better measure against which we can look at hospital capacity, if that's what our red line is for. We saw that it was a death rate per population in one of the other historical charts. So as you're looking at how these charts are coming out in these different models, definitely take a look at those y-axes and see what's actually being plotted. Thank you for coming to my TED Talk on Chart Chat. Would love to hear from my collaborators, though, on what you're thinking about in terms of taking flatten the curve and this idea and translating it into how we think about what this pandemic means to us and how we see some of this data coming out in these models.
That was fantastic, Amanda. I just want to pick you up on one line you said right towards the end and ask you to elaborate on it. You said how you consume or choose to consume this information. Can you? I think I know why you said that. Can you explain why?
I think the big question I've been asking myself, Andy, because I keep getting questions of which coronavirus or COVID-19 dashboard am I using to track new cases? I've been asking myself if that data really serves me right now. And at this point, I've been spending more time digging into literature or reading studies or things that come out about what we can expect and understand about the virus, the challenging choices that are facing some of our healthcare workers. That information helps me have a better understanding and wrap my head around what's happening than knowing if there were 5 more cases in Virginia yesterday. And that's not a real number, I'm making that up, but 5 more cases, X more cases in one place. And so for me, it's a question of how are we actually acting as individuals on this data and information? My day-to-day choices right now are not materially going to change. I'm social distancing, staying home, giving my nanny full paid leave right now to stay at home with her own kids because it's the right thing to do. And those are the choices that I'm making. And seeing a couple new cases on a chart isn't going to be the thing that changes my mind about what my choices should be as an individual.
That echoes my thoughts as well. It is as sort of data professionals, you know, we in normal times would be sucking this up, and you know, everybody's perspectives have changed, right? It's like, yeah, I'm thinking much more close to home.
I think the one we have a lot of questions on the chat window about, you know, capacity. One of the things that strikes me is, you know, where is the constraint? I'd say, you know, probably my favorite business book ever is The Theory of Constraints. It's probably helped me in the business world over my 20 years. And this really speaks to that, is that we just see this generic dotted line going across there about healthcare capacity. But what does that really mean? Every day, the governor of New York speaks about, you know, 3 things. Is one, you need beds. If you don't have beds, you can't put people in them. Then the next thing you need is equipment. If you don't have the ventilators to put people on, then the beds don't matter. And then the next one he goes to is staff. If you don't have the staff to run that stuff, then the beds and equipment don't matter. So the dotted line is interesting because what really is the constraint to the system? Is it the ventilators? Is it the masks? Is it the same in every place? In New York, you know, they may hit staff or ventilator capacity first, and someplace else they may not have that many ICU beds, and I think that's going to be a dynamic model and maybe a floating curve in and of itself. It may not be a flat line.
Well, and what can we move, right? Like, what's the easiest to reallocate? What do we have excess capacity of in one place that we reallocate somewhere else? And in disaster settings and humanitarian relief, that's often a big question, right? What resources do we have, and where do we need to get them to? And I heard a story on NPR just this morning about how are we reducing the barriers to our traveling healthcare workers and nurses being able to practice in different states where typically there would be more barriers to them being able to practice. And the people I worry for the most and see the most kind of just frightening comments for me about are just our healthcare workers and how we take care of them. So for me, all of the choices we're making to stay home right now are around buying the time for our healthcare workers to get more PPE, address some of these capacity constraints, and slow the spread.
That's very important. They said yesterday on the call, 16% of our new cases in Ohio were healthcare workers. So that's important. Yeah.
I'm going to transition in a moment to Andy, and one thing I'm going to ask Andy during or at the end is: do people get it? Do people understand this illustration, which has now become so mainstream? Do they understand it? Do they understand the ramifications of it? And I'll just share a little anecdote. We all know a colleague of ours reported yesterday that a freak accident with her 1-year-old daughter, who fractured her skull, ended up in the hospital, and she was thank God that the hospital was not already overtaxed, because they were able to take care of her 1-year-old daughter, and realizing it isn't just about deaths from COVID-19, it's about being able to care and tend to day-to-day emergencies. So with that in mind, Andy, would love to see some of the things that you've assembled about charts that have gone mainstream and bowled people over. I never thought logarithmic scales would go mainstream.
Yeah.
I'm echoing in somebody's so I'm going to and hand things over.
Can you see my screen, and does it say disclaimer?
Yes. All good, Andy.
All right, all good. Great. I'm actually going to focus just on one chart for the next 6 or 7 minutes. Just on that last comment, some of the other questions on the flatten the curve thing.
Andy, you are in presenter mode. That's what we're seeing.
The wrong slide. Yeah, sorry, that's the wrong screen. God, you'd think I'd done this before. Let's share that one and optimize it for screen sharing. But we're not going to share computer sound. Is that better? Much better. Great. Okay, yeah, I saw a lot of questions about uncertainty, and I think there's much more to discuss about how we visualize uncertainty, which is a perennial challenge and ever more so in this crisis. Okay, so I'm going to talk about one particular chart right from the top. I am not an epidemiologist. If anything I say sounds like advice about the disease, that is my error. It is not. I'm going to talk about a chart. Also, I'm going to talk a little bit about risk among younger people in COVID-19. Again, I'm not telling you what to do. I am not an expert in this at all. You should heed advice from medical experts, and that advice is stay at home to save lives. That said, let's talk about something the CDC reported on last week. The story you saw in the media is largely been about younger adults being a really big proportion of hospitalizations. So said the Washington Post and the New York Times, big portions for the younger adults. Eric Ding, who's a slightly attention-grabbing epidemiologist on social media, even said, young people, you are just as likely to be hospitalized as older people, and he shared the chart. So this is really a story that we see in normal times anyway, but it's just overwhelming and slightly terrifying of what we're seeing at the moment. The objective in this next 7 minutes is to consider how data communication and a chart with one story can actually become a virus itself and mutate and grow and change and evolve as it spreads across social media. And maybe try and take a couple of takeaways from what can we take away from this as we think about data. So here's the chart. It came from the CDC report published on March the 18th, analyzing 4,200 cases. Before we look at the chart in detail, let's look at the executive summary. This is what the CDC concluded. They said, COVID-19 results in severe diseases, especially among older adults. And yet the story that came out seemed to be a lot about younger people. So what happened? Well, the chart has an x-axis. On that, we have 7 different categories of age bandings. On the y-axis, we've got the number of cases in 3 categories, from 0 to about 140. And those 3 categories are, in light blue, hospitalizations, in medium blue, the number of intensive care unit admissions, and in dark blue, the number of deaths. So there you go. This is our chart from the CDC report on March the 18th. Now, we are programmed to look for the biggest, longest bars. What do we do when we read this chart? How do we interpret it? We see the 2 longest bars. We scan down to look at the age groups, and we see, wow, 20-year-olds and 65-year-olds. They are the people who are most likely to be hospitalized. Is that the right conclusion? When this chart was shared on social media with that message, was that actually what this data is showing? Some of you will already be ahead of me. 20 to 44, that is a 25-year time span. 65 to 74, that's a 10-year time span. The CDC had grouped, the age bandings are in different sizes, which is standard practice that the CDC and medical professionals would do. So I think if the bands had been the same size, would the story have changed? So let's take a look at this data in Tableau. So what we're looking at here is just hospitalizations. And I've got the same data, but I've taken out 0 to 19. And we can see the large bar for the 20-year-olds, or the 20 to 44-year-olds, and the larger bar for the 65 to 74-year-olds. And I was like, well, if we split this into 2 to make it almost equal, what actually happens? I've created 2 almost equal band sizes here. I don't know the underlying data, so I've just split them in 2, which is not correct, but the best I can do. And you can just see visually, we are drawn to a different story. We see the bigger bar and we see the 65-year-olds. That simple choice could be what has kind of pointed people to reporting the data in a particular way. So is this a bad chart? Well, let's summarize. This came from the CDC report on March the 18th, reporting outcomes for different age groups. The CDC's executive summary, if you went and read it, says what we're concluding is that it's especially among older adults. And yet the story that escapes and becomes the prevailing narrative is slightly different. We're focusing on the younger people, and erroneously in some cases, because you're not just as likely. That's not what the data shows. Now, I have seen people criticizing this as a result and saying this is a bad chart because they chose the age bandings that they chose, but that's misinterpreting the point. The problem is our interpretation of the data. The CDC are doing what they always do. They choose different types of bandings, and they, as domain experts, will be familiar with this. Perhaps they could have been more sensitive to how the outside world would interpret it, but in all cases, the burden is on us to actually be careful about what we're reading. Now, another profound question about this is, if you have a chart, it's very easy to read it, glance it, think you know what it's saying, and then share it on social media. This is the chart as it appeared in the report. This text here is the paragraph of text that actually exists in the report and describes the data. They are saying the same thing. The paragraph here is just talking about hospitalizations. In prep for this talk, Amanda asked me a really profound question. She said, what if they just hadn't put any charts in this paper at all? What if all you had to rely on was this? Well, then there'd be nothing for you to lazily and sensationally copy paste and share your erroneous conclusions. If you wanted to draw a chart, you would have to do slow system 2 thinking to read this data, create an Excel file, and plot it in R or Tableau or whatever. And I bet if you did that process, you would not fall into the trap of misinterpreting the age bandings. So it's really interesting how this crisis is just emphasizing this responsibility we all have at all times, but especially now. Our responsibility is to read and understand the source of any chart we look at. We need to pay really close attention to the chart design, because we don't want to be anybody who perpetuates or starts myths and erroneous conclusions. And, you know, to come back to Amanda's choose to consume, I think we have to choose what to share. I particularly am standing way back from social media at the moment because I don't want to be part of the problem, and I kind of feel like there's too many opinions around at the moment. I'd rather see things that are more factual. The second thing, there is a little aspect of this chart that I'm a little bit uncomfortable with, which just evolves on that process. When I looked at this chart, I saw hospitalizations, and I inferred that these hospitalizations led to this many ICU admissions, which led to this many deaths. Because of the grouping and Gestalt pattern recognition, it feels to me like this data point leads to this data point, which leads to the deaths. But the other thing that's incumbent on us all, especially as data practitioners, to read the footnotes, understand the missing data. And in fact, if you delve into this paper at length, you will discover some really interesting insights. So this chart represents what data they knew about, or what they knew about in the 4,200 cases. So hospitalization status, they had 4,200 records, but they actually only knew whether 64% of them were hospitalized or not. We didn't know about the rest of them. 47% of ICU statuses were known, whether they went into ICU or not, and the same similar number with deaths. And of those known cases, how many times did that thing actually not occur? So for all the known hospitalization cases, only 12% actually ended up in hospital. Only 123 of all ICU status known actually ended up in ICU. And of all the cases where death was known or not known, only 45 ended up. So if I was to redraw this chart, I might separate out those 3 bands to really sort of emphasize that they are not one subset of each other. I'd also put N, you know, what is the number for each one above it? That's really, this is not a bad chart, right? The CDC chart is not a bad chart. They were reporting their data in a dry, matter-of-fact way. The detail is in the paper. It's incumbent on us to be more intent about reading and understanding it, because what we're seeing is data just fly across social media, as we always do, but now it's more and more dangerous. Our job, and this is my final slide, is it's been incredible sort of seeing the genesis of this chart and watching it fly across social media and see the stories evolve. Our job as professionals is to be aware of missing data, spend more time looking at source, and really understand the chart design, because I would hate for any one of us, anybody on this call, or anybody in this field to be responsible for some of these misinterpretations.
Well, and Andy, I hate to jump in here, but I think you may have actually made a tactical error as you were reinterpreting the chart.
Oh gosh, go ahead, tell me.
If we actually look at the report, there were the 4,226 cases reported that we had data on. And the first way that they segmented the data down before even looking at hospitalization status is look for where we had known age information. Where did we have an age classification? So there were only 2,449 cases with known age information. And then of those, only 508 had a known hospitalization status. So only 12% of cases actually had a known hospitalization status, of which we could then place which segment actually were hospitalized.
In which case I will scratch from, we will, yes, thank you, Amanda, for correcting me.
I just think it speaks to the complexity, though, right?
Yeah,
so if
I spent several hours highlighting this paper, and it's really hard to interpret it. I found things that I seemed erroneous, right? I'm like, this number, in fact, this number doesn't seem to match this number in this paper, and it's probably me. In fact, as you've seen, it's me, right?
Yeah.
So yeah, there you go. I don't know. Do you have comments?
Well, I did just want to address one of the comments that came up in the question before we dig into the chart itself a bit more, which is on the age banding, right? Why is 20 to 44 actually go ahead and get picked? And oftentimes in public health, we're looking at age bands that are comparable groups of people, right? So it's common to see youth, adults, and then older populations grouped together. So you'll see the 18 or 19 and under, 20 to 44, but really usually 20 to 60. Sometimes, and then over 60, and then those get subgrouped by age. And my guess, and I am not the person looking at this data at the CDC, but my guess is that the reason for breaking out the elderly groups in more granular detail here is because of the fact that we do know that this disease does have a larger impact on elderly populations in terms of severity of outcomes. And so that helps us understand a bit more. But yeah, it's tough because this is a question about the data quality, right? So we're looking at only having demographic data on age for 58% of those US cases. So when we have kind of mediocre quality data to do these kind of analyses, how much should we be really making really bold statements in charts and graphs about the data itself? And it gets back to that uncertainty question.
And that kind of leads us to our next topic. I'm happy to see that I'm no longer feedbacking through somebody's speakers here. Andy, I know that you didn't have time, but in terms of that graph being co-opted and spreading a message that was incorrect and possibly incendiary, we've also had some heroes in terms of data visualization. I'm thinking of John Byrne Murdoch, Financial Times, and you've already mentioned Harry Stevens. Hopefully we'll have an opportunity to look at that, and hopefully we'll have an opportunity to look at logarithmic scales becoming mainstream. I usually am very reluctant to do that, but hopefully we'll have a look at that in a little bit.
I just wanted to, John Byrne Murdoch, I don't know how many people are following John Byrne Murdoch from the Financial Times on Twitter or who read the FT, but you know, he's been doing the logarithmic scale projections of city and regions and country, and you know, I'm consuming them every day and they're incredible. One thing I've noticed is how each day the charts actually have more annotations added to them, and yet because we're all reading them daily, you know, if you step back, the annotation layer is really quite busy now from something I would normally think, oh, there's too much annotation on that. But because we've seen each layer build up day by day by day, they're additive, and we're kind of going along that iteration journey with him. And so suddenly I'm feeling able to consume a huge amount of information on that chart. Whereas if he'd started with that overload of annotation, it would have been a lot harder. There you go. Each day there's more information, but still I can follow it. I could see William McHenry's just to put an interesting comment, saying one of the reasons for the stories to be reported about younger people is because we have to get you, because it seems that it might be that younger people have been less likely to adhere to the social distancing guidelines. And so, is there a validity in the media using some sort of nudge tactics
and
sort of make that point?
That's a good question. Governor Cuomo of New York, and during his briefings, which are in fact probably happening now, but as this is being recorded, that is also being recorded, so you can watch it, is trying to bludgeon millennials with this notion of, look, you can catch this, you can spread this. He has not said, oh, and you're as likely as anybody else to be hospitalized. He has not spread that because we don't really have enough information to do that, but he's trying to make it very clear, do not think you're impervious, or do not think that you will not do great harm to others by refraining from social distancing and adhering to the recommendations. So thank you, my friend and classmate, William McHenry, for asking that.
Can I ask a quick question to Amanda from Anthony Starks, because I know it's an important topic to her. He asked about thinking about how we humanize these charts and the implications of making this in more human terms. I thought Amanda would like to speak to that.
I think the humanizing piece is tough when we're talking about communicating about something as sensitive as infections or deaths or other pieces like that. I think that in the Reuters graphic, to me, is one way of humanizing it in terms of using iconography and terms of people. I mean, you can't scroll down that page without just feeling an overwhelming sense of sadness for the fact that that whole group of people were infected just because of one choice one day. I do think that also part of humanizing data is being able to see yourself in it, which is where I think some of these pieces that allow us to say, what does this mean for me where I live, like that ProPublica piece I referenced, is really helpful for saying what data of all this data that's out there, what data is relevant to me. And me as a millennial, by the way, Andy, I think the sadness should be placed, or sorry, Steve, should be placed more on Generation Z than millennials right now. We're the ones who faced like 9/11 in high school, and then we graduated from college, and then went ahead and we faced a crisis of the economy. And now as we become new parents, we're dealing with a pandemic. So millennials are, for awareness, people who are my age.
Sorry, I am merely parroting our governor here in New York. Jeff, could you do me a favor? Could you share again the Financial Times and scroll down not to the deaths, but to the number of cases that are there? And I'm going to imagine a little further down, that's city, and now we have trajectories. There it is. It's the one that you had a little further up, not the small multiples, right? And this is the country by country, how many corona case trajectories compare, and this desire to China being somehow not something that we can relate to, but you want to see how is my country, my neck of the woods doing, and in the context of these other things that we followed. So I find this a very sobering graph that we are doubling almost every 2 days in the number of cases, or it's between 2 and 3 days, closer to 2. Also, most of the people who are attending to this webinar right now are probably steeped in data visualization, but if you look at the scale along the left side, that's not a linear scale. And more people are becoming familiar with how to read something like this, and I never thought I would see the day where a logarithmic scale would go mainstream as it has with here, and this incredibly good work from the Financial Times, which we're starting to see a lot of other organizations report as well. So this is an example of some great work and something that I think should be amplified. Amanda, I'm going to hand things back to you and Jeff in a moment about kind of the ethical responsibility. I have not published any visualizations on this whatsoever. I am very frightened to do so and inadvertently amplify or spread misinformation. And I'm now very reluctant before I retweet or share anything on Facebook because I have inadvertently given a mouthpiece or a larger amplifier to someone who may or may not have warranted that amplifier. So Amanda, what say you?
And might I add, though, I think on those Financial Times charts, before we pivot on the things that people are doing really well, I think there are some really small nuances that John has put in those around, like normalizing against days since 100th case. Yeah, Jeff, you could pull that up. When you look at that x-axis, it's helping us understand and relatively size and scale people or countries based on where they are in their epidemic curve, which I think is a really smart choice. It's not just starting at January, right? And so it helps us compare information better. And someone asked the great question on the chat about why we're looking at absolute cases and not looking at rates. And this early on in an epidemic or in a pandemic where we still are really early stage in terms of having all that data, and there's a lot of uncertainty in the data, normalizing against population isn't as meaningful, and it's not what our epidemiologists are looking at as much. It's not to say that you can't look at that in context, but at the end of the day, it's kind of when someone says, well, how much do we really trust these numbers in the US? It's like, I don't know. We're not testing widely enough, and we're recommending people who are symptomatic not be tested because we don't have enough tests. So we just don't have a really good enough or certain enough numerator to make those statements. I'm going to go ahead and switch over. Jeff, I'll flag over to my screen now, and we'll wrap up with a couple short slides on coronavirus influencers, because that's a thing now, apparently. Who knew? I'm not an epidemiologist, but the rise of the coronavirus influencers. What happens when Twitter engagement decides who's in charge of the public health crisis? Because I know I'm paying a lot more attention right now, even than ever before, to what someone has in their bio and checking out what their work looks like. So Thomas Pueyo is one that I think a lot of folks saw, as he's kindly flagged. He's had over 40 million views with 30 translations on his article and has written a follow-up. If you, he has flagged a list of EPIs and experts who publicly shared or endorsed the article, because there's some good information in there, right? It's a lot of information all in one place. He certainly overstates the certainty of early case fatality rates in this article, which was my big initial flag to this being not maybe done by an epidemiologist. And he's currently being represented by a content marketing firm. Check that out, promoting Pueyo and his coronavirus article to journalists and being very excited about the celebrities endorsing his post. But as I look at who I'm listening to and who I'm trying to learn from, I'm looking for people who have subject matter expertise. I'm transparent in that I am not an epidemiology in my Master's of Public Health program, but I am a public health data person, and that's how I self-describe. So let's compare two people. Allison Lynn Hill. Allison, a research fellow at Harvard with some great experience in this space, a whopping 1,421 followers on Twitter, and Thomas over here with his 28,000. And when we look at Allison, her whole reason for being and what she does is to develop mathematical and computational tools to help us better understand, predict, and treat infectious diseases. This seems really relevant right now, right? This is the kind of person that I am looking to and trying to amplify and learn from. And cool enough, Allison has built an entire interactive R-Shiny app that let you actually really see the complexity of what these models are. Again, every model is wrong, some are useful. When you look at this, 27 different parameters can be changed on the interface for this model. And then it will output different charts or graphs, as you see on this little slider across the output, of whether you're charting spread, the interventions, capacity, those kind of things. She has detailed information about her sources, her code, and this is publicly available. And I would argue that if you don't understand very well what you're doing or what is meant when you pick different inputs on these parameters, that maybe this isn't the space to start dabbling and building basic models and telling people what might happen. And the reason for that, the reason this is so much more, I think, complex right now, is because people who trust us as data people are making decisions about what they do, social distancing or not, staying home more or not, based on what we share. I've seen that with just the conversations I've had with my own parents. And so I think it's really important that we think about amplifying the experts in this space. And there are some great interactive tools. This new one from the New York Times makes a key point and makes something that might be very complex from Allison much more accessible, right, for a wider audience. And this was, I will say, developed in partnership with epidemiologists and experts. And it makes a very clear point around what might happen with case numbers if we only do short-term social distancing versus long-term. And just the staggering difference in the size of these curves is notable. And this is where I think we just have to remember that bringing our data viz expertise together with subject matter expertise, that's where the magic happens. When Harry Stevens has talked about how he created the interactive explainer, he talks about how it was a collaboration and an engagement. There's a new article, an interview with Desk magazine that he and I were both in, talking about that process for him and the ethics of what we share. And so as data viz people, I think we have to think about how do we bring those subject matter experts to the field? And that's not just going to be health people. When we start to understand the economic knock-on effects, I'm not an economist. I want to hear from economists on what they're seeing and looking at and thinking about. So I would ask all of you, how do we make this magic happen?
Well, I want to amplify the example from the New York Times. That's from Nicholas Kristof, who is an editorial writer, and he collaborated with 2 epidemiologists and 2 mathematicians to come up with this. And I think of Pueo, who is a good explainer. And there were some charts in there that had a visceral impact on me if he were to do the same thing. So I would love to see that type of collaboration between journalists and people well steeped in the data science and those are the things that we should be amplifying. So if you don't know what you're talking about, shut up. And before you retweet something, look at who is behind the items that are there.
Yeah, I have a question. Were there errors in Thomas's article?
I gave up reading it halfway through at 26 minutes. I eventually decided it wasn't worth my time. But my biggest challenge I saw with it was I thought it really when it started getting into really overstating the certainty or not explaining the uncertainty very well around case fatality rates early on. And I get that that's a challenging balance, right? Like when I talked to my dad, he said one of the things that was most impactful to him wanting to do more social distancing was seeing a high case fatality rate estimated for his age group of someone who's older and is high risk. And so if it causes people to do social distancing, it comes back to the question that was kindly asked on the Q&A of what are the trade-offs of being a bit more directive about giving information that doesn't have a bunch of caveats with it, so someone takes appropriate public health actions and behavioral changes versus explaining the complexity.
Could I share my screen, Amanda, one last time here? I think what hit home is kind of the intersection for me of the SME and the data viz profession. I think we've probably all seen the Johns Hopkins data and thankful to a group of people, Anya Ahern and Alan Walker and Jonathan Drummey and Tomas Foldy, who put together, a data repository that we could tap into. This is something that's getting so many views that people use every day to track. And I think, there's just things that maybe the other side of the house could use from the data viz people, right? We're not experts in epidemiology, but they may not be experts in visualizing data. And I think about choices that are made sometimes. I think about, okay, well, is, red, are we inciting panic with that? When I did a redesign of this, I specifically tried to get away from the red just to showcase, okay, let's not maybe incite with those numbers. Maybe we can clean that up a little bit and maybe, I don't know, we talk about in our workshops the use of color, right? Andy's got a great example of the Iraq war, numbers and just how a simple color choice could make a choice there. Chantilly did the same thing when she visualized that data using that. And Anya herself, when she created the starter dashboard for companies or people to use when they're accessing that data, just, not specifically using those colors. And then I look outside of that, our Ohio Department of Health every day is on a call with our governor at 2:00 and they're using data viz. They're using Tableau, in fact. And so, 2 days ago, they started publishing these numbers county by county, the daily increases. And I just have that opposite reaction of, what could our field do to help them, right? If we could get together and put that magic together, we could probably hit that sweet spot of things that we could do together, right?
And might I make a plug actually for the fact that the Data Visualization Society, as part of that desire to do good, actually launched a matchmaking program for bringing together people. I'm echoing.
I think you're okay.
Bringing together people from different backgrounds who are able to go ahead and pull together both organizations and David's folks. I will put a link in the chat.
So, folks, we're going to wrap up fairly soon. We will have our next chart chat on April 16th, and there is the URL to sign up for it, and also various resources around the Big Book of Dashboard, which was the entire catalyst for chart chat, by the way, as well as a recording of today's episode will be available shortly, and other resources are at bigbookofdashboards.com. I'm going to stop sharing. Andy, you wanted to end with a couple of, well, I'll just hand it over to you and you can describe it.
Yeah, so it's a hard time for everybody trying to visualize data, but one of the things we did in the Big Book of Dashboards was talk about the screaming cats of data visualization. So to end on a slightly light note, there are some visualizations we found where we're just like, what were you trying to do? This one comes from the Daily Mail. It showed cases in the US, I don't know, it was about a week or 10 days old. And the thing that amazes me about this, it's the amount of time the person must have taken to create this. It's not only just a crazy chart, it's you could have made a beautiful infographic in the time of that one. And then the second one I saw was this one from the Australian media site down in Australia. How contagious is the coronavirus? And I just don't know what the percentages mean. They add up to 100, but I just don't get it, and it's awful. So on that note, they are our two screaming cats. I am sure the people who made it had the best intentions. I suspect they were directed to do something, but I don't think they were helpful really for anybody. That's it.
So I will leave pretty much, if you get to this URL, you will find where you can sign up for the next chart chat. You can find recordings of previous chart chats. The
recording will be available tomorrow.
Amanda, Andy, Jeffrey, thank you so much for the stellar work, your friendship, and camaraderie. Thank you all so much. It's been great having you today.
Thank you.